Now we move to part 2. If PTH is suppressed, think outside the parathyroids. The high calcium is not being driven by parathyroid hormone anymore, so the differential becomes PTH independent. The first major cause is malignancy-related hypercalcemia. This is one of the most important causes to recognize, especially when calcium is very high or rises quickly. The key mechanism is often PTHrP from solid tumors. Hypercalcemia can also come from lytic skeletal metastases, especially breast cancer, and from multiple myeloma. Next, think of excess 1,25-dihydroxyvitamin D production, or calcitriol-mediated hypercalcemia. Activated macrophages in granulomatous disease can produce extra calcitriol. So remember sarcoidosis, tuberculosis, leprosy, fungal infection, foreign body reaction, and lymphoma. The mechanism is increased calcitriol, causing increased intestinal calcium absorption. Now separate that from vitamin D intoxication. Too much ordinary vitamin D usually raises 25-hydroxyvitamin D. Excess calcitriol or activated analogs raise 1,25-dihydroxyvitamin D. And CYP24A1 deficiency causes reduced vitamin D breakdown, so active vitamin D effect persists. Another bucket is increased bone resorption. Think hyperthyroidism, Paget disease of bone, and immobilization. Ketogenic diet is also listed, but it is uncommon. The key idea is simple. Calcium is being released from bone into the blood. Then ask about calcium load. Milk alkali syndrome and total parenteral nutrition are high-yield examples. These are easy to miss unless you ask about supplements, antacids, diet, and treatment history. Medication history matters. Review the drug list carefully for thiazide, vitamin A, lithium, foscarnet, teriparatide, and aromatase inhibitors before chasing rare diagnoses. Now keep a rare cause bucket for exams and pattern recognition. Adrenal insufficiency, pheochromocytoma, acromegaly, VIP-oma, denosumab withdrawal, recovery phase of rhabdomyolysis, Williams-Buren syndrome, and pregnancy or lactation-related PTHrP. Finally, do not miss pseudohypercalcemia. Total calcium may appear high, but ionized calcium may be normal, for example with calcium binding, IgM in Waldenstrom macroglobulinemia. So when the setting feels unusual, confirm with ionized calcium. So the Part 2 framework is this. Suppressed PTH means malignancy, vitamin D or calcitriol excess, bone resorption, calcium load, drugs, rare causes, and the pitfall of pseudohypercalcemia. Follow the mechanism, and the table becomes much easier to learn.